And so I'm going to go ahead and kind of start in order. I'll try to ask Dr. Meese your questions first, since I know you have to go to a back-to-back lecture here coming up in a few minutes. So the first question that came forward was, is there any evidence of any bowel perforations in the trials with Tremfya?
A good question. I'm not aware of any specific. There's certainly not a call out for that, as there have been for other agents. And so whether or not it ever occurred, I don't know the answer. Chad, I'll throw that back to you to see if you know of any specifics on that.
Yeah, I'm not aware of any.
Good. If you don't, then that's probably the case that there were none.
The next question here is, does Tremfya work in patients with peripheral disease with minimal or no axial involvement in PSA?
Sure. Yeah, I mean, I think that we went through that data pretty carefully, that there's quite strong ACR responses, and we didn't really get into it, but some of the higher thresholds of disease remission and low disease activity have also been looked at, and yes is the answer. So clearly peripheral enthesitis, arthritis, dactylitis are very well treated with this agent.
Thank you. There's a question here. It says, are there any markers that would suggest that guselkumab should be a drug of choice?
Don't we wish? So the answer is no, unfortunately. But there are all kinds of folks that are, including the National Psoriasis Foundation handed out some pretty substantial grants in the last couple of years to try to help us with advancing biomarker science in psoriatic arthritis. And Chris Richland and others are hoping to get some future support from the NIH in that regard as well. And so we are, and GRAPPA has a group called the Collaborative Research Network, where we're just beginning on doing some translational studies, both in Europe and North America, to try to advance the biomarker science. And that's one of the goals, is to identify biomarkers that can teach us what would be the best mechanism of action to proceed with in a given patient based on their particular immunophenotypic profile. And we've got some glimpses of what that might look like. I won't prolong this too much longer, but there was a fascinating study that came out of Japan where they used FACS analysis and identified patients that were a bit more TNF predominant or IL-17 predominant, for example, and found that they could get better responses if they would pick treatments based on that particular type of careful FACS analysis. And that's what we're hoping to get to in the future, but with simply drawn blood test biomarkers.
Thank you. And this is an interesting question. It says, Dr. Meese talked about the BASDI data, the axial data that we presented, at least in symptoms. Are there any data on Tremfya use for uveitis or inflammatory bowel disease? And I'll just remind you, this is an off-label question.
Okay. So I'll comment on the second item first. There are, as we speak, trials progressing in inflammatory bowel disease with Tremfya. There is substantial evidence to suggest that an IL-23 inhibiting medication can be effective in IBD. And as you know, the drug ustekinumab has been approved there, and presumably partly because of its IL-23 inhibiting mechanism. So we are anticipating that there will be, if such trials go well, that there may be a pathway toward use of this particular mechanism in treating IBD. And so we have reason for optimism. Let me put it that way. Although at the moment there's not a formal approval. Uveitis is another issue, and I'm not aware of any particular data that tells us whether this mechanism will be particularly helpful in uveitis or not. We're not seeing signals from the trials that it's harmful in uveitis, i.e. seeing any more than expected flares of patients with baseline history of uveitis. So on that one, I'll have to say I don't know.
Thank you, Dr. Meese. And this is a question for both you, Dr. Meese, and Dr. Song. I guess this question is really evolved around, when you're trying to pick a therapy and you consider products like Tremfya and Stelara or Symphony for a patient, what are the type of things you think about? And obviously, Symphony is not approved for psoriasis, but it is for psoriatic arthritis. So if you could comment maybe on how you go about making a decision for an individual patient.
I'll start with that, and then Jennifer, you can pick it up. So so it's a little bit hard to say, oh, this particular type of patient should have this, and that particular patient should have that. I suppose the temptation there is to say that if a patient has really severe skin disease, then you might pick ustekinumab or guselkumab ahead of golimumab for that particular patient because of the just the sheer magnitude of effect that we're seeing in the skin with these IL-23 inhibiting medications. However, having said that, we saw good data with golimumab in the skin, even though it's not approved in psoriasis, but in the skin of psoriatic arthritis patients, as well as in both forms, the subcutaneous and the intravenous form. So on the other hand, if I had a patient with until we get this answer for the spondylitis thing sort of more nailed down, if I had somebody in front of me that had really, active spondylitis, then I might go for golimumab in that situation because we've got a known approval of that drug in ankylosing spondylitis. And I would just simply say, let's wait and get some more data on guselkumab in that regard. The one other thing I would comment upon has to do with the totality of the safety data that Jennifer went through in good detail. And that is that I think that with both ustekinumab and with guselkumab, we're not seeing any malignancy signal. We're not seeing we tell patients about infection, but the overall serious infection rate appears to be very low. We're not seeing an IBD flare issue. And so I think the safety profile it may be something that they really resonate with. Jennifer?
I agree with you, Phil. Other considerations are also, for me, is most of the patients that come to see me have their primary complaint of skin, right? And so in those situations with higher skin clearance rates, both in for Tremfya, and that's why head-to-head data that we have here versus a TNF like Humira and an IL-17 like Cosentyx is very, very helpful. You see a clear difference among the drugs. And other considerations like Dr. Meese mentioned, whether their history, safety is a big factor for me as well. So that's why I highlighted some of the differences in the package insert when I was talking about the important safety information for Tremfya.
Thank you, Dr. Song. There's a question here for either of you, and that's any difference when it comes to side effects, monitoring, or time to benefit compared with a product like Stelara?
So, Chad, I'm going to, if you don't